Hello. Hello.
Hello.
Sir, I opened the room for attendance.
Yes, you can.
Sir.
Faculty has not yet joined only. And you can send me the YouTube link so that I can share with everyone.
Okay, sir.
Hello, sir.
Hi, Suresh.
How are you, sir?
I'm good. How are you?
All good, sir.
So I messaged everyone to join. Just wait.
Right. Sure, sir. Sure.
Hi, Navita.
Hello, good evening, everyone. Good evening, sir. Good evening, Abhishek.
Dr. Chabra from attendee to the panelists, please.
Dorcas is joining in 2 minutes.
Hi, sir.
Yeah, can you see me now?
Yeah, Dr. Chabra.
Yeah, sorry, I joined as a panelist with the other. Sorry, yeah.
If all the panelists have joined, then we can start the program.
Sir, 2 people are still pending, sir. Dorcas and Dantala are joining.
Dorcas is here.
I think Dantala also is in the members. Just take him as a panelist. Asmita?
Yes, sir. Please join as a HP.
Yeah, PS Dantala.
Attendees, there is no as a Dantala.
He has come as HP. Just take him in.
Good evening, sir.
Good evening. I think all have joined. We can start, sir.
Yes.
Good.
You start as chairperson.
Yeah, I'll start, sir. Yeah. Good evening, everybody. On behalf of IFNR, we are organizing this special panel discussion on World Spinal Cord Injury Day, and we have started a panel of full multidisciplinary team, spine surgeon, rear physician, physical therapist, occupational therapist, as an orthotist to discuss the burning issues on SCI rehabilitation. We have a very good moderator, Dr. Surya, the president of the IFNR. I know the dais to him to start the proceedings. Dr. Surya, please.
Good evening, friends. And at the offset, I welcome all the panelists here. It's truly a multidisciplinary panel to talk about how do we handle the spinal cord injury rehabilitation. And before I start the question and answer and come to all the panelists, I would like Dr. Chabra, the president, Spinal Cord Injury India, and the man who has been working with spinal cord injury for last many years, and he is, chief of Spine Services and medical director, Indian Spine Injury Center. He has held so many positions, and he has been, principal man behind, with, of course, Professor Ahluwalia, who started this center in working in the cause. So before I really start the panelists to grill them and put some questions and ask them about this, I would want Dr. Chabra in next few minutes to tell us why, after all, this SCI day, what is the importance? What does it matter to you and the public around, all around us? What is the significance and why you have been doing this, so that people should know that why it is important to have awareness about spinal cord injury. You all know that yesterday we lost one of the greatest star in Indian country, the big businessman Shapu Palunji, the biggest sort of the builder in the country. Not only builder, they have been tremendously respected people, Parsi community, and he died in the road traffic accident. 2 people died and 2 has been still grievously injured, admitted out of 4. So road traffic accident are real fatal. When somebody very important person dies, we all start thinking, "Are accident aisa ho gaya? Kyun ho gaya? Road pe khadda tha kya? Speed tez thi kya? Kya hua?" Lekin we really don't look at the family who lost the people, and the worst, the people who have spinal cord injury, quadriplegia, paraplegia, they're suffering for whole of their life, spending the lifetime or future for the treatment. And therefore, I would request Dr. Chabra to please give a background on this and why it is important before I take the questions.
Thank you, Dr. Nirmal Surya. Thanks for the opportunity and thanks for your kind words. I think it is teamwork, like we are doing it in a team fashion here, and that's how spinal cord injury management has come all this way. So very relevant, especially for spinal cord injuries. With regard to your question, we know that spinal cord injury is perhaps one of the most devastating diseases that can afflict mankind, but the common public and other stakeholders are not aware about this. We also did a study in which we found that one of the commonest cause of neglect in spinal cord injuries is lack of awareness, and awareness not only amongst the community but across all stakeholders. So recognizing this, International Spinal Cord Society thought about having 5th September as a spinal cord injury day. Idea is mainly to create awareness. Create awareness, one, that spinal cord injury is preventable, as you were talking about. 2, that if someone gets a spinal cord injury, it's still possible for them to get back to a normal lifestyle. In fact, we say that we have come to a stage where persons with spinal cord injury, their lives can be happy, meaningful, and worth living. But there are substantial gaps in this knowledge, and we need to create awareness amongst all stakeholders to create the necessary infrastructure for management, to provide the necessary aids and appliances, to train the personnel, to create an accessible environment so that there can be a proper community inclusion. So for all this, the awareness needs to be created also amongst the policymakers or the government, amongst the healthcare providers, amongst the professionals, amongst the media, amongst professional societies, amongst the community in general. So to focus attention on this it was decided to observe 5th September as a Spinal Cord Injury Day. And we thank you all for contributing to the cause in this regard. You are muted, Dr. Surya.
Perfect, Dr. Chabra. So we know that today is the Spinal Cord Injury Day, and we are really involved in creating an awareness. But can you give in a brief, what is the current scenario of spinal cord injury rehabilitation in India? A person get an accident, he goes to the hospital, the neurosurgeon or spine surgeon fix the things, operate if they're ready for, if there's a fracture, dislocation or compression, they operate. Next 1 week, post-operative, patient is quadriplegic. So now where they have to go? What is there? What is available in India? Where they should go? Can you guide us?
Yeah, you have raised a very important issue again here. There are two issues. One, where do they need to go? And two, also the awareness amongst those operating upon that surgery is just one small component of the management. The individual still needs a comprehensive rehabilitation, which is not only physical rehabilitation, but also psychosocial rehabilitation, sexual rehabilitation, vocational rehabilitation, rehabilitation back into the community. So I think you have also touched the point that facilities for comprehensive rehabilitation and management of spinal cord injuries may not be available across the length and breadth of the country. So there are very few centers providing comprehensive management. More so important, personnel trained in all components of spinal cord injury management are not available. Assistive technologies, for example, occupational therapists are available, but not that common. But peer counselors, assistive technologies, you need a multidisciplinary team, and very often the entire team is not available, and you have one person multitasking for the various other things, or like sexual counseling, fertility counseling may not even be provided to a large number of patients, right? Vocational rehab may not be provided, and they may not be also be made aware about the importance of preventing complications and a lifelong follow-up. I think there are still centers which are providing this, and this information should be available. I think at least the professionals should know where to refer these patients. But also the government of India is setting up more rehabilitation centers, more spinal cord injury centers. In the next 5-year plan, I think there's a provision for 15 more such centers, so that there is one at least in each state. But that also can't meet the needs of the entire country. I think if we train the personnel in the PMR department in each medical college across the country to provide services for spinal cord injury, we have a very simple answer. Spinal cord injury management doesn't need a lot of equipment, etc. All it needs is trained personnel. And we have to find a solution in that regard so that you can actually tap what is possible for these persons with spinal cord injury to be achieved, and they are not.
Perfectly agree with you, Dr. Chabra, that we really need to have much more centers which should be oriented toward the management of spinal cord injury and providing a proper rehabilitation. And you have raised the point of multidisciplinary team, and we got physiotherapist Dorcas here from Ludhiana, and we got Dr. Suresh, who is from Ireland and who is an occupational therapist, and we got pain specialist Dr. Navita is here, and we got neuro rehab specialist Abhishek right there, and I'm the neurologist. There are 2 or 3 thoughts which maybe you can put forward to the government of India while these centers are established. Wherever there is a neurosurgical unit, they should establish a spinal cord rehab center, or rather than it should be a trauma rehab center, because in all community, the joint injury in the brain and spinal cord is very common. So many of these patients, about 40% patient, may have head injury as well as spinal cord injury. And it is very fitting that all neurosurgical centers should have an associated rehab setup where the minimum you have at least the multidisciplinary team to take care of the both head injury as well as spinal cord injury, which will address the cognition and vocational. So I come to Dorcas. You are from, again, an institute. How does the physiotherapist, play a role, and when they come into the action, are you have been called on day one of a spinal cord injury? You have created an awareness of stroke rehab, and there people are now calling you on day one of stroke. So what you think that rehabilitation is challenging, particularly for physio with grade 0 power in lower limb, patient just been operated or been mobilized with the various gadgets. So what are the challenges of physiotherapists, and others, particularly around T6 and above we are talking about?
Thank you, sir, for that very relevant question. If we have to talk about our center, like you very rightly mentioned, the stroke unit is very well developed. Under the mentorship of Dr. Pandian, we do get calls on day one, right in the acute, hyperacute phase. We are informed as a multidisciplinary team. However, for spinal cord injuries as such, the protocol is not set, even if our institution is found to be a really well-established tertiary center of care. We still struggle with neurosurgeons understanding the value of physiotherapy care right from the acute phase, even in spinal cord injuries where patients have been given a green signal clearance from the medical side. For example, there are a few patients who could have been managed really well right from the acute phase. We could have avoided a lot of muscular wasting, atrophy that happens, that begins really early in such patients. We sometimes are not allowed to shift such patients who have medical clearance into a rehab room where we could use, in machines like the tilt table where weight bearing can happen, where a paraplegic patient otherwise cannot do. A simple support through walker may not be sufficient for a paraplegic patient. So things like tilt table, things like mat exercises, suspension that physiotherapists use could be brought into use in such cases, where that is where we exactly need early referrals. And like sir, you mentioned T6 and above, there are so many autonomic issues, autonomic dysreflexia, postural hypertensions, that physiotherapists also have a role to play in, not just in prevention of them, but also to deal with them when we work as a team. So early referrals definitely is a big issue that we face even in a well-established tertiary center.
So that's right, that physiotherapists become the key person to start mobilizing, and they have their own challenges day one. So I think we would urge the neurosurgeon, orthopedic surgeon to have a referral right on day one. Navita, you know that you are managing the bladder and bowel disturbance and spinal cord injury, whether anywhere from cervical to the lumbar. The bladder and bowel are the one which get completely involved. And how do you start managing from day one? What are the thoughts come? How you explain to the patient? How you explain to the relative? What are your protocols for both bladder, bowel? Of course, I'll come to you later on sexual aspect also, but acute care, long-term care, how do you, because this is something in this spinal cord injury patient, if not taken care, many of them can go into the chronic septicemia, renal failure, and that's what is the cause of death in many of these patients.
Yes, sir, very rightly said that the main cause of death in these kind of patient, if not treated, is a UTI. And they have to be the first and foremost thing which we do is with assessment and reassuring the patient. How do we go about it? Because if we don't talk to the patient and the family what we are doing, so they always think that they will get better, and they will, depending on the Asia scale, we have to prognosticate, and we have to tell them right from the day one, once the patient is out of spinal shock, and whether we have to assess whether it's an element or a UMN type of bladder or the bowel which we are looking at. So the management differs a little bit in both the cases. So we have seen even the patient who come chronically, they are on Foley's, and they are never been spoken about what the bladder would be managed, and what about the bowel. Bowel is the less common after the sexual being spoken about to the patients and the relative, and they always have this dilemma: how do I go, how do I manage? Okay, Foley's hai to chal jayega, but aage kya? But then Foley's has its own UTI, its own complications. So we start with the patient education, and then after that we do some we can start with lifestyle modification and some dietary management in the form of fibers and in the form of the fluid intake. We have to tell them what should be the right fluid intake. The current guidelines, which has been published in 2022 from ISCOS, says that 1.5 to 2 liters of fluid should be a person should always take in a day, and around 20 grams dietary fiber should be included in their diets. And then after the conservative means, we can add some modify their lifestyle changes, and then we can talk about how do we evacuate, because sensation, evacuation, and control, these are the three things we look for. So evacuation, we can tell them for abdominal massages, and how to increase the abdominal pressure by using some abdominal binders, or telling them, the therapist, that okay, if they are not, if they are paraplegic or quadri, then just flex their knees and then increase the abdominal pressure, put the pressure on the abdomen. And then is dilating the anal canal, that is the digital stimulation, because using the anocolic reflex is very important in these patients. So once when anocolic reflex and also gastrocolic, so after having something, after 30 minutes, we tell them to make a bowel program, to sit on a commode chair and then start. It's just like a toilet training in the kids. It's just like that is what we do. And we also encourage digital stimulation, that is using a gloved finger and then just stimulating in a circulatory manner in the anal canal, and doing it 15-20 times, and waiting. That is again is stimulating the anocolic reflex. In element, we do get hard stools, and manual evacuation is what is being taught to the patients, that we have to look for. The PR is very important even after the evacuation of the bowel, and see whether the rectum is empty or not, and then manually evacuate. If these they do not help, then they do have, because there's a problem of constipation, and there's a problem of incontinence, and sometimes there's something called as a overflow incontinence, which is the fecal overloading, but it is not coming out. So that is a spurious diarrhea. So they experience, they say, have a small quantity of bowel, there's a leakage of small quantity of motion, but they do not fully evacuate it. So we have to look this thing, that it is chronic constipation which we are looking at, or really it's the diarrhea which we are looking at. It is always misdiagnosed as a diarrhea. It's a spurious diarrhea. So we have to again do a digital the PR, which helps us to know whether we are dealing with the constipation. It's the overflow constipation. So we can, because of the slow transit, because the transition period reduces, so we have to use some pharmacological agents for prokinetic drugs, which has helped a lot. So we can use these kind of, which is by the trade of Provit, which acts on the lower bowel, that can be started in these kind of patients. And once when we come to that, the pharmacological, the conservative, then also suppositories and enemas, micro enemas,
So-
they do play an important role.
What you
And-
have highlighted, Navita, is that it is very, very important that beside whatever treatment is going on, bladder and bowel is
management.
very, very important, because if patient has got constipation, it can cause pain. If the bladder is distended, it can cause pain. And once the pain is there, it can aggravate the spasticity, particularly the patient with T6 or above level thing. So there can be a cycle of pain, spasticity, constipation, and really we need to look after that. This has been taken care. Very well explained, and I think we will come back to you again. Suresh, what is OT role in a spinal cord injury? I thought that cervical cord injury, you have an hand weakness. So, I mean, people may not even know what occupational therapist is going to do. Dr. Chabra mentioned occupational therapist, ADL. So would you highlight that how important it is an occupational therapist, not only in the cervical cord injury, but also for the lumbar and dorsal spinal cord injury? And how do you help the therapist, the PMR specialist, the neurosurgeon together?
Thank you, sir. This question is very relevant to all the occupational therapists as well as healthcare providers as well, because most of us don't know who we are. And most of us, even people who finished occupational therapy, they think that in the national scenario, they are considered as someone who's a hand specialist, not someone who can look at anything other than hand. However, I would like to stress that occupational therapy is the science of healing through occupation. And occupation is anything that we do that is purposeful and that takes time. And if you actually take the sentence that I just said into consideration, even blinking of the eye is an occupation, because you do it for a purpose, and then you use it for some time to achieve a particular goal. So in general, occupational therapists help somebody with any kind of disability get back to their normal activities of daily living. And by activities of daily living, I mean activities that you do as soon as you get up from the bed, which are self-care activities like grooming, brushing, toileting, bathing, and getting ready for work. The second aspect is if you're a child, you will play. If you're an adolescent, you will get into schooling and college. And if you're an adult, you'll go for work. And if you're an elderly person, you will actually manage leisure and kind of manage home as well as participate in the community actively. So all these have got an issue when you become disabled, especially when you become spinal cord injured in this context. And you will not be able to get back to these normal occupations as soon as you became disabled. And as occupational therapists, we'll enable somebody with this kind of disability to get back to their normal activities of daily living and engage actively in the society and be a productive member of the family as well as the country. In terms of the way we work with the rehabilitation team members, again, I would like to say that there's not much awareness and knowledge about how an occupational therapist can contribute as a member of the team within the spinal cord injury rehabilitation in this context. And I would definitely say that anyone who comes for care to either a rehabilitation center or to a hospital will definitely want to get back to their activities of daily living. For example, I have been very active. I met with an accident. I'm unable to move now. So my first need will be to get up and then stand, use toilet on my own, and then kind of move around, get back to my schooling and things like that. However, we are very, very essential as a part of the team in terms of setting the goal. So the person, when you ask, even if it's going to be a rehab team without an occupational therapist, if you ask him, what do you want? He will obviously say that I want to get back to what I was doing before the accident or before the spinal cord injury. And to plan what has to be done, not just relevant to physical rehabilitation, but also a comprehensive mix of biopsychosocial rehabilitation. The goals can be effectively set if an occupational therapist is there as a part of the spinal cord injury team. You're muted, sir. Sorry.
Sorry. Absolutely. You highlighted why activities of daily living are important, why we need to get the patient back into the integration into the society like he was before. Dantala, you are your video is off, and if you could see, yeah, there you are. So Dr. Dantala is a orthotist. He's one of those orthotists who has started long back, and we specifically called here because, again, like occupational therapists are unknown, hidden in a multidisciplinary team, so are the orthotic. First, there are very rare and few orthotics, good orthotics available in this country, and Dantala is one of them. So what are the role of orthotic, Dr. Dantala? I want to know, are you called in each and every spinal cord injury patient right in the beginning? Or patients search you somewhere and then they come, now I need a stick or I need something to walk. How is your experience and how you could help this patient at early stage?
Thank you everybody for inviting us for this forum. First of all, Dr. Chabra, wonderful this thing. And today's, I would like to thank everybody on Teachers' Day, because with all your mentorship only we are here, and with all the patients' input only we are able to deliver our experiences. As sir very specifically said, orthotics, people feel it's a very specialty field where we make the orthotic supports to support, stabilize, and then to move on, you know, and a prosthetist who makes an artificial parts of the lost body part. So in spinal cord injury, as sir very specifically said, sir, the first requirement is in an accident is an ambulance caller, which is the very, very important aspect of spinal cord injury. Any spinal cord injury which has to be mobilized worldwide, they have a ambulance callers, immediately they put on and then they transfer. Like we have stretcher beds where without lifting the patient, you can shift him onto the stretcher. You put on both the sides and there is no further more damage to the spinal cord. So these kinds of technologies are available in the orthotic point of view. So spinal cord injury in a good city level setup, definitely the orthotics has a very, very important role, like first of all to support and stabilize, further to prevent contractures. We have so many equipments for the spinal cord injury patient, like for the technology side, we can see we have motorized wheelchairs, standing wheelchairs, and there are a lot of developments are coming. In India, still we are in the verge of developing things, but definitely very, very important role played by an orthotist in the spinal cord injury patient. Like if you want to mobilize a paraplegic patient, bilateral HKFO is the only solution where we can mobilize the patient.
Right. So we heard about all the multidisciplinary team. We have got one person sitting here who is the most expert, though he is the chairperson. Abhishek, I want to ask you one thing. That, you know, whenever I see spinal cord injury over the experience of 30, 35 years, I have been into rehabilitation. Patient either have bad sores, or have contractures, or have developed a fixed joint. They come to us maybe 2 or 3 months later with these things, where their power has improved quite significantly, but they are handicapped or bedridden because of this. How common are these problems, and can they really be prevented before this happen? And how do we deal with them?
I rightly said, sir. The most common or most preventable thing the medical or rehab team can do is to prevent secondary complications. And we call it MBBS, mouth, bladder, bowel, and skin care. If we can just educate the nurses, the rehab team members, and the patient caregivers or family members how to clean the mouth every day, how to turn them every 2 hours, how to do basic range of motion exercises for all the joints, how to make them sit out of bed once in a day, at least 30 minutes morning and evening on a wheelchair, how to clean the catheter every day, how to help them pass motion every day. If we can teach this MBBS to all our patient caregivers, we can prevent most of the secondary complications. Only when the secondary complications are not there, patient can go for rehab. If they have these complications, they'll be struggling with medical issues, antibiotics, braces, medication. They can't participate in rehab. So these are preventable things, and patient education is the key part of that.
Absolutely. I think you have rightly said, and I feel that with the multidisciplinary team, the one person who should be right there from day one is the caregiver. So we have to have a social worker or a caregiver as part of the team, because team may change, but that social worker or caregiver from the family will remain with the patient. And therefore, I think what you have pointed out is very, very important and very relevant. Dr. Chabra, I come back to you. Now, you know that spinal cord injury are so common in this country. You are running a center. I can imagine that out of all the cases across the country, you may not even be dealing with 1% cases. So what are the real challenge we have, and how do we, how the spinal cord injury center, are they going to open up the centers, branches, or are they training the people to take care of this? Are you integrating all those social organizations who are there? Like we got in Mumbai a couple of them, and they have been working. Can you not channelize them and overcome these challenges? So first of all, I want to know what are the challenges and how you can overcome them, get together so that a quality care can be delivered.
Thank you, sir. You very rightly mentioned about the challenges, the inadequate amount of centers providing comprehensive care, the inadequate trained personnel in all components of spinal cord injury management, the inadequate awareness amongst people for the need for a comprehensive management. Other than that, financial issues are also important. And we did a study in which we found that except for the upper Kupuswamy group, most of the others in the socioeconomic strata will not be able to afford spinal cord injury management. And in a country where insurance plays only a small part and people have to pay for themselves, even higher middle income group family would not be able to afford the costs of spinal cord injury management. So then comes the barriers within the environment, right? Accessible environment, right, where everybody can lead an inclusive life, that is there. There may be some provisions for assistance to persons with disabilities, but people don't know about them. There are bureaucratic problems in also tapping them. So there are numerous challenges which are there across the country in this regard. And I think it requires a cumulative effort from all stakeholders, right? Whether it's the government, whether it is the professional societies, healthcare providers, whether it's us professionals, everybody need to join hands to be able to achieve a solution. So as you were mentioning, if we can have, I go a step further, not only for spine and brain. We know that any locomotor disability, right, the facilities required are the same. And official census say that 40% of all disabilities are at least locomotor disabilities. And unofficial census says 10% of persons in India will have some form of the disability or the other. So if you look at 40% of that 10%, it's a huge population that you need to cater to. And if you can create facilities for locomotor rehabilitation, which may not look not only for spinal cord injured or those with brain injuries, but all locomotor disabilities, I think we have an answer to that. And all we need to do is fine. The more the gadgets available, we may be able to get better outcome. World is moved from therapy only for maintaining muscle tone to the plasticity of the spinal cord for a better recovery. But a basic rehabilitation only needs two hands, right? Doesn't need a lot of equipment. And all it needs is training of personnel in each medical college PMR department. And you can make a difference, I feel. And for that, we need to have we need to include spinal cord injury management and locomotor disability management in the curriculum of all disciplines, not only doctors, right? All the multidisciplinary team where it is required, it needs to be included in their curriculum. That is the requirement from the regulatory authorities, right? The government needs to partner with private associations or private healthcare providers to be able to create facilities for management. The healthcare providers should not only look at what they earn out of a person with spinal cord injury, they also have to look at what respite they get to them. If they make them productive, economically productive members of the society, the whole family lives. Otherwise, practically, it's the death of the whole family. And the government also needs to see what costs they can prevent by spending a small amount, because otherwise, as Dr. Srivastava was mentioning about the complications, etc., you spend more on management of the complications of these patients than on them. So the community also needs to understand, they need to cooperate in prevention programs and everything. So you need a combined effort from all stakeholders. Professionals need to fulfill their responsibility. And I think we can make lives for persons with spinal cord injury happy, meaningful, and worth living. So it needs a will, and I'm happy to inform that the government is moving rightly in this regard. They are committed to set up more centers. 2 days ago, we just finished with the injury prevention workshop for finalizing the injury prevention program of the country. 1st to 7th is being now organized as an injury prevention week. But this all required all related societies to get together and sensitize the policymakers in this regard. And that's where the role of societies like ours comes in.
I agree that challenges are many, and it's not only its responsibility of one person, but multiple stakeholders, right from the government to the society, to the doctors, to the team. And I think challenges are there, and we will come back to that further if we have time. Doctors, what are the things you think among the physiotherapists? How do you plan, and what are the options people have as a therapist? So, you are looking for acute therapy, and then you're looking at newer things like, robotics and all those exoskeletal. There are so many things has come which many people might not have even heard, and many people may not have access also. Tantala will also tell us something about AutoWorks and all. But can you tell us that how the plans are, and what are the changes has happened in past couple of years in the rehab program, which can be very, very fitting to improve the people with spinal cord injuries?
Yeah, thank you once again, sir, for that very relevant question. Starting off with the assessment part, we are now as therapists, we are able to have at least a general sense of what prognosis the patient will have with respect to sensory motor recovery, using things like RTMS, using things like transcranial direct correct stimulation, SSEPs, motor evoked potentials. There is so much out there. However, like you and Dr. Chabra has already highlighted, the capacity of the workforce, the quality of the workforce in general needs to be built to use these services. So starting off from understanding the prognosis of the patient, we have moved so much from there, and we have also been able to develop and improve the intensity with which therapy can be given through robotic systems, through gait and postural analysis, not just through in-person evaluation, but through remote evaluations as well. So these are two major things that I think we need to keep in mind as therapists, which will definitely change the whole direction of therapy we provide to the patient. We understand the probable prognosis the patient has. Based on that, plan a goal, intense goal setting regimen with the caregivers, with the multidisciplinary team, and then decide a treatment regimen which will be specific and customized for the patient. This, I guess, with the little experience that I have, was not possible, probably a decade ago. And now we have access to all of this.
Absolutely. So Dantala, you want to add on to that? What are the new things patient has? I may be paralyzed, but yet I am being able to do fully work. I mean, the wheelchair is such prominent. There are so many movies which has come.
Yes, yes, sir. Very rightfully she said, because generally with this spinal cord injury patients, mobilization is very difficult. With the evolution of the robotics, as Dr. Abhishek sir has a wonderful department, you must have seen, lifting the patient and then making them back their movements of the legs, hip, and then foot is a very difficult task. And without the latest technology and the robot assisted, exoskeleton assisted orthotics, it is really impossible. So these technologies are available in few of the best hospitals in India, but very long way to go in India. Definitely the SCI patients are very well recovered with this kind of treatment and approach, and the results are fantastic. I think Dr. Abhishek sir can give more highlight on this, because he has one of the best center in India, I would say. So no doubt on it.
Absolutely. I do remember Professor Gelu Onoso, one of the principal chair of the spinal cord injury in WFNR. He was chair for special interest group for long year, along with my friend Bajo. And Gelu himself has suffered from spinal cord injury. He has traveled all over the world in the wheelchair with his wife. He has delivered so many lectures. He has done so much of work. So I think if you decide that you can do the work and you can do what everything can be done, there are so many Paralympics who has been doing great. Veena Malik is something who's done. This year also, a couple of people have won the gold medal in table tennis. So it's all, again, the facilities are there now. How many of them really decide to get those facilities, and how many of them receive? These are the challenges. And I think if somebody takes it, and people like Dr. Chabra and the Spinal Cord Injury Center, I'm sure they would be able to help those people who are willing to take themselves into the stream and fight as a normal person. So a lot of new gadgets are available. And there the question comes for Suresh is, what do you think, how you reintegrate these guys? So, where the role come now. So I decided, okay, I got this wheelchair. Now, how do I start working, travel on the road? India roads are not good. I see so many people when I go to US, they are in the wheelchair. They're nicely speeding on the footpath. They're comfortable. They go. What about India? Are we going to do something for that? And how do you integrate them?
Thanks for that question, sir. So I would say India has got lots of architectural barriers as well as attitudinal barriers. And the attitudinal barriers is something that we have to address first, especially right from the goal setting of a rehab for person affected by spinal cord injury, whether it's high level, low level, whether it's complete or incomplete. Especially because what we think of is an institutional facility where we have lots of gadgets, like Dr. Dantala was saying, And we can definitely make him do whatever we want within the institution. But after he gets discharged and he goes back home, can he use the powered wheelchair to the toilet in his own home? It's not possible. And after we give him, say, knee, ankle, foot orthosis bilaterally, and then train him to walk with crutches and calipers, can this person sit on the ground to have his food as he used to do it before? So can flow transfers possible? Have we thought about flow transfers? The third thing is, okay, I can do everything at home, but I want to get back to my work. Now, how will I climb a bus? How will I actually stand in the bus? How will I take a ticket with 2 crutches in my hand and with the rush that we have in these normal buses? Then comes this architectural barriers. So I would say right from the beginning, when we set goals, we have to set goals depending on where this person is living and how much he has got in his pocket to get the rehab done, and what is the possible solution for him to become an economic member of the family. So it can be an altered job, it can be the same job with some amount of say skills and training for it, or it can be a completely different job altogether. And in terms of the previous question, you were talking about how do we get along with this and how do we kind of look at alleviating disability. As Dr. Chabra was saying, we are just looking at a national program for injury and injury prevention at this point of time. And since we are talking about health and wellness centers, replacing the primary health centers in all the areas of the country, we can obviously have one rehabilitation setup within the health and wellness center to call it by the name. So we cannot say primary healthcare and health and wellness center when there's no staff or no system in place for wellness. So if that is possible, then we can probably look at an integrated multidisciplinary comprehensive rehab happening at the health and wellness centers that's nationally there, about 650, I think. And probably that becomes a part of primary care, and we can ensure the spinal cord injured are empowered right from the beginning.
Thank you very much for giving the view on how the occupational therapist could contribute and be part of the team. Navita, we come back to you. Now, there's something which has not even been discussed, talked, neither by the patient, nor by the doctors, nor by the family person, nor by the wife or husband of the patient. And that's the sexual rehabilitation. I think this is very challenging because after first few months, when patient has come out of the acute crisis, how do you handle this? Because this is something which is quite challenging, frustrating maybe for the partner. So how do you encounter this? How you guide them and give them a way forward to live the life normally?
Thank you so much, sir. This is absolutely not much talked about, and in countries like India, it's if we talk about it, and especially in the rural setups. When I was doing my PG, when we were talking about sexual rehab, and when we were discussing about it, when we were questioning the male partners or the female partners, they were not ready to come out with the answers. But now things have changed, and with the advancement of, when we are talking of robotics, and the advancement has taken place in sexual and fertility also. So we have to, once they gain our confidence, and when we are doing a multidisciplinary and a multi-modal approach for the rehabilitation of the patient, when they see that they are now able to move around independently, whether it's a wheelchair or with the crutches or with managing their bladder and bowel on their own, doing SIC or CIC, a tender CIC. So they themselves, they come and ask, and this is the time when we do have to ask them, and we have to question them. We have to, what was the pre-morbid sexual activity, and what is it now? And we have to counsel them that there is a hope, how to go about it, and if they are married, then how to be with their partners. And we have to find out in males and females if there's a little bit of difference. And the females, we say that there are chances, you can go ahead and think about your family life. We have to counsel, and when we talk to the female, if female is the injured patient, then we have to take in account the partner as well, and both of them, they have to sit in the counsel and to be counseled that things can happen, and they have to be taught about how activity, and there are different positions which can SCI patients, we have a chart, and we share with them how to, depending on the different levels, how to go about the activity. And then the females, the only thing they face problem is that they don't feel if they are talking about T6 and above, so they don't feel the labor pain. So the cesareans is what we should plan the delivery, and the CS is what we always look for. In males, there's a different scenario because erection and ejaculation is what we talk about. So we have to talk about the reflex, the 3 types of the erections, and ejaculation is difficult for them. So there are and sometimes the sperm count also it is reduced, the sterility and fertilities when we discuss about. So we have to do all the investigations, and then there are certain the vibrators which can help in ejaculation, and then there are different medicines are available for improving the erection, that is what sildenafils and tadalafils. So that can be given to them before the sexual activity, but we have to be very careful when we are talking in outer is very important. So we have to be very careful, and then this is how we can help, and then we can give a choice of IVF and artificial insemination in these kind of the patients, and this is how we can, in brief, we can help them in bringing out in reproduction and sexual activity, so that they're not deprived of this important aspect of life, and that is how we can complete the comprehensive rehabilitation.
Absolutely. I think this is very, very important and relevant to carry on to the life normally, because otherwise the frustration can build up and psychosocial issues are never ending with the couple. So we are going into the last phase, and Abhishek, very, very disturbing and devastating thing which happens. Families already been devastated. And then come this miracle therapy, the big advertisement, the stem cell therapy will cure you. People are injecting in the middle of the sea, not only in India, but outside India, China. There are people running all that full courses, and stem cell therapy will cure you. Could you highlight what this humbug is and why this is not a form of treatment? Because I know of that people have sold off their houses, sold off their rickshaw and all those things to hope that their family person will get better. So please guide the society that what is stem cell therapy for spinal cord injury and why it's not a routine treatment.
So stem cell therapy means we take a cell from any part of our body and which can grow into a neural tissue, and which we implant it at the surgical site or intrathecally or intravenously. Studies have shown that you can take it from nasal mucosa, you can take it from the umbilical cord derived cells, you can take it from bone marrow. 3 common sources are there. You can inject it surgically at the operated site, intravenously or intrathecally. There were at least 20,000 studies in last 15-20 years on stem cells and spinal cord injury, but there is no single RCT to show that stem cell therapy helps people with spinal cord injury to regain neurological recovery. People are doing it day in and day out at different centers. Whatever protocol is available right now, in these protocols, patient are given stem cell injection followed by 6 months of intensive training. There is no study to show if you do only 6 months of intensive training, are the effects similar to stem cells plus 6 months of training. And I can assure you at most spinal cord injury centers, D7, D8 level below paraplegics are independent for functional mobility. They can manage their bladder by SCIC. They have a good bowel program with a good sexual health. That doesn't require stem cell. That primarily require multidisciplinary integrated spinal injury rehab. So rehab is the key. Stem cell might be in future have a role to play, but in today's circumstances and current scientific knowledge and literature, there is no study to show it's better than SCI immunity rehab.
Absolutely. One of my friends, the great spinal cord surgeon rehabilitation program, Dr. Humberto Bajo, is watching us on the YouTube, and he has been very kind enough. And I remember visiting his center 3 years ago, just before the COVID, in the near the Venice, and his place. He had one Indian young woman who got married, Sardarji, the lady Sardarni, and she had a car accident living in Italy, and she was wheelchair bound. And I remember Professor Humberto made sure that he said, Dr. Surya, you have to give the counseling to this person in Punjabi or in their local language. I said, I don't know Punjabi, but I'll definitely speak to them in Hindi. So he made sure that I spent about 1 hour along with him to discuss with that patient that what is the level of injury, what are the things the hospital is going to do, the rehab department is going to do, and gave them the plan that these are the things in next 6 weeks, 12 weeks, 6 months, 1 year is how it's going to be happening. So I remember this, and Humberto sent me a message that I'm watching you, listening to the sexual rehabilitation, how different countries have different level of rehabilitation and requirement. And I completely agree, though they are different in each country because of the culture and the racial aspect. But ultimately, it is the same goal, getting back the patient back to as much normal as possible. And I give you an example. Now we are running into the last few minutes. I give you an example. In 1990, when I just passed out the neurology, and I had one of patient, in Surat, shot with 3 bullets, and 2 bullets went into the lumbar region, I think around L3, and he was completely paraplegic and with severe pain, the bladder bowel involvement, both the legs completely weak. He had hypotension. He was nearly on ventilator for a couple of days. And then I shifted him from Surat. He was in Surat, one of the businessmen. We shifted him to the Bridge Candy and started. And then came the 2 big surgeons. They wanted him to operate. The big neurosurgeon. And I said, nothing doing. We treated him. The bullets are still there. We treated him, made a comprehensive program, and put him on proper physiotherapy. And you will, Dr. Chabra, you know that I said Chabaria. Dr. Chabaria was my physiotherapist, the senior most physiotherapist. We worked together at Bacha Hospital. That's how I was interested in neuro rehab. You will not believe that man is walking with very minimum disability, no catheter, and he today is doing a farming business in Kutch. He left Mumbai and he is now in Kutch, Mahendrabhai. And we took him to the London, to David Ruston. Those days, David Ruston was the rehab specialist at London Medical School. This I'm talking of something around 94, 95. And David Ruston said, what rehabilitation you got in India when we had nothing is what is the best, even I can do it in England. So what I want to say, I'm not going to say that I have treated. What I want to say is that simple principle following and therapy, preventing complication, as Abhishek has mentioned, and giving the right guidance to the people and their family is what is most important rather than carried away. So Dr. Chabra, last word from you, how we are going to face the spinal cord injury in 2030.
I think we have come a long way from ever since spinal cord injury was revolutionized. And this will be an ongoing process. I think, as you mentioned, we have to first live today. We have to empower our persons with spinal cord injury to be able to tap what is possible today. And we should not sell dreams to them, as you had talked about. I would rather say that it is criminal to try to delve on the sentiments of individuals with such a devastating calamity and try to sell dreams to them, something which is still experimental, which as per regulations you can't charge for. And I think it is our responsibility to prevent all that is happening, not only in India, but across the globe. We have published also in this regard, do we need to move from regulations to legislation? That is the time that is there. On the other hand, would also want to know that, want to inform and share that there's a lot of research which is taking place across the globe. We have come a long way from the time of the Second World War, when the management was revolutionized. Spinal cord injured today can lead a near normal lifestyle, but things are improving by the day. Brain-machine interface, neurostimulation, exoskeletons. There are a number of possibilities which will keep unfolding. We don't know when the answer to a cure will happen, right? But when it happens, everyone across the globe will know. The person will win a Nobel Prize for sure. Till such time, we should not rely only on media reports which keep harping, I gave stem cell and the person started walking. So we have to, in a scientific world, we have to rely on science. I think we have come a long way. Our country has a lot of strengths. I think the amount of family support and community support that is there in India, you seldom see anywhere. Though it can work like a double-edged sword, it can prevent in the rehabilitation also. We are innovative. Our religious beliefs also help us in cope better. And we have produced some people who have been so successful despite a spinal cord injury. I think the news that the knowledge that we need to impart is life does not end with spinal cord injury. With the power of the mind and a positive attitude, you can achieve far more than what the able-bodied can. And I think with that spirit, right, we should carry forward with the hope that someday we'll definitely have a cure for spinal cord injuries.
Thank you very much, Dr. Chabra. I hand over to Abhishek for his last comment, summary, and closing of the session.
I think we have very important discussion. Some things came. First is injury prevention. Second is timely intervention, be it surgical or non-surgical. Third, patient and family education to prevent secondary complications, followed by multidisciplinary rehab. Fifth is judicious, I would say judicious use of technology, be it robotics or be it electrical stimulation. No role of stem cells at present. And proper bladder, bowel and sexual rehab, followed by good vocational training so they can go back to society and earn a living, take care of themselves and their family. And it's only possible, Dr. Chabra says, with two hands when they work together in the multi-site team. I think with this message, we close this session. So thank everybody on behalf of IFNR for a wonderful, wonderful panel discussion. Thank you very much.
Thank you, everyone. I hope you have enjoyed the show. And any questions can be written on ifnr2012@gmail.com.
Thank you.
Thank you, sir.
Thank you. Thank you so much.
You all.
Thank you. Bye-bye.